Yes.
Yes.
Okay, great. That's perfect. All right, so I'll run that for you, Carolyn. And then I'll stop sharing and okay. And Lauren, if we get to the point and I mention our institutional sponsor, and he hasn't gotten on yet, just be like, he's not here yet. And we're laid back too.
Okay. He said he needs the link, so try to.
Hey Bailey,
Yeah.
does he need to register for it then?
Yeah, he'll have to go in and register, and then it should let him in,
Because if he uses one of ours, he'll come up as us.
which is fine. I mean, he can change the name too.
But yeah, would it be
I'm
easy
not-
for Lauren just to send him the link?
Yeah, I think that would.
Okay.
'Cause I'm not sure what time the registration will not allow you to register anymore.
Okay. All right.
Is it okay if I start admitting people now?
Yes, please.
Yeah, I'm gonna hit the admit all. Yeah. Good evening, everybody. I'm going to allow just one more minute for people to join, and then we will get started.
-10.
All right. Good evening, everyone. I'm Carolyn Wilhelm, and along with my co-chair, Don Park, and the SOPE Education Committee, we would love to welcome you to this evening's speed session dedicated to QI in the Pediatric Echo Lab. We would like to thank our institutional sponsors, especially our newest sponsor, Children's Minnesota, that also have Seattle Children's, Lucille Packard Children's Hospital at Stanford, Nemours Children's, Cincinnati Children's, Kentucky Children's Hospital, Ann and Robert Lurie Children's Hospital of Chicago, Rady Children's, and Akron Children's. If you're interested in being an institutional sponsor, please contact us, the email there that you see, for any more information. You can also find us on social media. Here are all the different ways that you can connect with us on SOPE. And then don't forget to re-up your SOPE membership. You should have received an email if you're already a member to renew. Otherwise, please contact us if you're interested in joining.
All right. Thanks, Carolyn. So again, I'm Dawn Park. I'm so excited to have everybody here tonight. We have our institutional sponsor for the night. It's Cincinnati Children's. And we were seeing if Carlos was on yet.
I do not see that he's joined yet, Dawn.
Okay. All right. So what we will do is we will highlight the sponsor at the end of the session. And I will introduce our moderators for the session. So we have Lauren Huff. She is a cardiac sonographer at Children's Hospital Cincinnati. And then Dr. Samantha Holmes. She is a fourth-year advanced cardiology fellow, finishing up her fellowship at Children's Hospital, Colorado. So I will let you guys take it away, and I'm going to stop sharing here.
All right. So first up, we have Megan Beatty, who's a clinical assistant professor in pediatric cardiology at Lucille Packard Children's Hospital at Stanford. She specializes in transthoracic fetal transesophageal echocardiography. She completed her cardiology and advanced imaging fellowship at Boston Children's, and she is the director of the Echo Lab Quality Improvement at Stanford, and her other academic interests include 3D echo and left heart obstructive lesions.
Thank you so much for the introduction, and thank you for the opportunity to speak with you all this evening. Thanks for joining. So I'm going to be talking with you tonight about quality improvement in pediatric echo, discussing established methodology, as well as giving examples of how we pursue QI at Stanford. So we'll start out by talking about different ways of defining or targeting quality improvement in echocardiography, review a sample case from one of our quarterly M&M meetings, discuss methods and example projects for improving quality, and then we'll end by touching on some of the multi-center projects that have been aimed at a broader impact in QI. Given the brevity of this talk, I'll really just be scratching the surface of all of the incredible work that's been done at pediatric centers across the globe. So one of the major ways that we can assess quality is by identifying, reporting, and reviewing diagnostic errors. This is a landmark paper from Benavides et al. That was published in Circulation in 2008, and it provides a taxonomy for categorizing the error type, severity, and preventability of diagnostic errors. Error type can be categorized as false negative, false positive, or discrepant diagnosis. Severity is categorized based on clinical impact, with minor errors having no real impact on a patient's course, moderate errors placing the patient at risk of an adverse event, and major errors leading to an unnecessary invasive procedure or long-lasting adverse event. And then a catastrophic error is one which is felt to have contributed to a patient's death. The preventability is categorized as preventable if, in hindsight, the correct diagnosis could have been made based on the available images. Possibly preventable if the diagnosis could have been made with different imaging conditions or additional images, and preventable and not preventable if the error was due to a limitation of echo imaging. They also provide a rubric for categorizing the cause of each error, such as procedural factors like an incomplete anatomic assessment, cognitive errors, or technical factors like suboptimal acoustic windows. In order to record diagnostic errors as they arise, we have incorporated error reporting into Singo, our echo reading software. So if a member of the Echo Lab notes an error or discrepancy with a prior echo report, or if an error is brought to their attention, such as by a surgeon on direct operative inspection, then they can log the error directly in Singo. So we have a dedicated QI tab, and the section for diagnostic accuracy has a pop-out free text box for recording the details of the error and how it was discovered. And then there are additional pop-out sections if the reader would like to provide categorization for the clinical impact or the preventability of the error. And then we can use the data mining function within Singo to compile a list of the reported errors for review each quarter. And errors can also be reported via email to me or our Echo Lab director for inclusion in our review. We have quarterly meetings to review our errors, which people can attend either in person or over Zoom. All of our attendings, fellows, and sonographers are invited to attend, including those from local Stanford affiliate practices. Our senior fellow typically presents 3 or 4 cases in detail, including the most relevant images, and then the group agrees on the most appropriate categorizations per the Benavides taxonomy. All of our case presentations are kept anonymous in terms of the identity of the patient, as well as the sonographer and attending that were involved. And we emphasize that all of our discussions are really for educational purposes at the beginning of each meeting. Our group also requested that we notify people involved in the cases that we're going to review ahead of time, which we do via email the day before the conference. We discuss learning points from each case, as well as potential action items to avoid making similar errors in the future. And minutes from our meeting are sent out to the Echo Lab, as well as any other members of the Heart Center who were involved in these cases or brought them to our attention. And then we end the meeting by talking about great catches or cases where the sonographer or attendings had particularly notable wins or made challenging diagnoses, just to kind of end on a positive note. So I wanted to include at least a couple of echo images in this talk, so I thought I would share a case from one of our quarterly meetings. This was a neonate with double outlet right ventricle with severe mitral stenosis, so single ventricle physiology. And this baby was born premature and small for gestational age and was under 2 kilos at birth. So he was initially managed with pulmonary artery banding and maintained on prostaglandin, given his low weight and concern for going on bypass. Several studies were performed early on in the first several days of life with images like this of the atrial septum that appear to demonstrate low velocity left to right flow across the septum. On these images at 1 week of age, we can see that the atrial septum is malposed quite leftward, and there's color flow acceleration through a very small communication at the posterior wall of the left atrium. The mean Doppler gradient at this time was approximately 10. And shortly after this study, the patient went to the cath lab and underwent atrial septal stenting. In hindsight, reviewing those prior images, the low velocity left to right flow that had been commented on was really not truly at the level of the atrial communication, but was sort of further along the septum. We categorize this case as a false negative error of moderate severity since it placed the patient at risk of an adverse outcome, and thought that it was possibly preventable since we would have needed more thorough sweeps of the atrial septum and additional spectral Doppler in order to make the diagnosis. Another way of assessing quality is through evaluating study comprehensiveness. The recent JACE guidelines by Leo Lopez et al. Include beautiful example images that serve as a very useful reference, as well as detailed descriptions of all of the recommended components of a complete initial study. In addition, several quality metrics are linked from the ACC section on adult congenital and pediatric cardiology, as are shown in this table. And these include checklists for assessing comprehensiveness, image quality, appropriate use criteria, diagnostic accuracy, and critical results reporting. So this is an excerpt from the ACPC metric for study comprehensiveness. This snapshot shows the checklist items for situs, veins, and atria, and there are multiple other sections that cover the ventricles, valves, and vessels. So our lab routinely audits study comprehensiveness as part of our ongoing ISC accreditation, as well as general QI. And we use the ACPC checklist, which has been incorporated into our QI tab in Singo. So you can see the study comprehensiveness section with multiple sort of pop-outs to complete. So here, the section on atrioventricular valves is shown. And so you can see the level of kind of granularity of what needs to be shown to be considered a fully comprehensive study. And after completing all of the sections, there's some score to allow us to see how many components we're missing, if any. There's also an ACPC tool aimed at assessing and optimizing image quality. In some ways, assessing image quality can be daunting because of the potential for subjectivity, but the ACPC assessment tool offers an objective way of grading image quality as part of routine audits. So a small excerpt from the first section is shown here that focuses on image orientation in the standard views. So we also include image quality assessment in our IAC reviews, and the components of that ACPC tool have been input into our Singo QI tab as well. So here you can see the expanded image orientation section, and within each component is a description of how the imaging should ideally be obtained. So this is the how the apical 4-chamber view should be obtained with kind of additional details about how it should be oriented. And then just to give another example, in the 2D imaging section, the section on optimizing brightness level gives a pretty detailed target for what should be done to be considered ideal versus needs improvement. We have a number of ongoing initiatives aimed at improving quality in our lab that I'll just go through a few of them briefly. With regard to improving diagnostic accuracy, particularly for our preoperative patients, we've started performing secondary reviews as well as a dedicated preoperative echocardiogram for inpatients. For our secondary reviews, we initially had targeted all first-time overnight studies on patients who would likely require surgery. And then we broadened it to not be limited to just those patients whose initial studies were done overnight. And then we also recently started requesting that inpatients have a dedicated preoperative echo performed, even if they had a very comprehensive initial study. Part of the rationale behind this was to reassess the anatomy after the transition from neonatal physiology with lower pulmonary vascular resistance and often ductal closure, as well as wanting to make sure that our assessment for inpatients is just as comprehensive as that for outpatients who go home and then come back for an outpatient preoperative study when they return for surgery. One of the major ways that we assess our study comprehensiveness, I mentioned, is through our IAC audits. We review the results of these data as a group during one of our QI rounds meetings. And a more specific project that we've undertaken for a particular patient population is to standardize our echo surveillance of inpatients with single ventricle physiology who haven't yet undergone the Glenn operation by creating a protocol to delineate both the components and the standard timing for our comprehensive follow-up exams. This project has been a very collaborative effort with colleagues from the CVICU and single ventricle program and has been aimed at improving outcomes for this vulnerable population. In order to work on improving our image quality, we have monthly QI rounds meetings, which are informal discussions on specific topics related to obtaining high-quality images or more accurate measurements. Example topics from recent QI rounds are shown here and include how, when, and why to measure the left atrial volume, how to optimize LV function measurements, and how to image and classify VSDs. And then I wanted to briefly highlight some of the fantastic multi-center work that has been performed in pediatric QI, in pediatric echo QI, such as implementing a pediatric echo appropriate use criteria and designing an educational intervention to improve adherence, creating a pediatric echo complexity score, and validating a tool for assessing image quality in pediatric echo. And I particularly wanted to highlight the work of my co-presenter tonight, Dr. Natarajan, who led a multi-center effort aimed at assessing preoperative diagnostic accuracy, for which 14 participating centers in SOPE comprehensively reviewed almost 1,500 consecutive surgical patients to identify and categorize our errors according to type, severity, preventability, and cause. And there's many exciting future directions for this collaboration to explore QI initiatives across multiple centers. So thank you all again for the opportunity to speak with you this evening. And thank you to our wonderful team at Stanford who support and participate in this work.
Thank you very much, Dr. Beatty, for that wonderful presentation. So I am excited to present our next speaker. So as already mentioned by Dr. Beatty, so Dr. Natarajan is an associate professor of clinical pediatrics in the Perelman School of Medicine at the University of Pennsylvania and attending cardiologist at the Children's Hospital of Philadelphia currently. She leads the quality subcommittee in the echocardiography lab and is the director of quality improvement in the cardiac center. She works with multidisciplinary teams to improve patient outcomes, both within the hospital and across heart centers.
All right, first, I have to try and get this window here and then go to presenter view. Okay. So I really want to talk about my favorite topic as well as Megan's and a lot of other people here in this room, and that is quality improvement in the Echo Lab. Our objectives today are to look at our statistics because we have quite a big lab, just like Stanford does. Look at team learning opportunities, do QI in terms of decreasing unnecessary variation and improve productivity in the Echo Lab. Talk about multidisciplinary efforts, both within the cardiac center and echo-based multi-center initiatives. So we have a big lab. In 2024, we read about over 40,000 studies, which is higher than the past year. So it keeps going up. And you could see the subset of studies that we read. We have 16 locations, 36 sonographers, and 41 echo readers. So there's going to be variability, and we're just trying to minimize it as best as we can. So for that reason, we have three subcommittees, research, education, and quality. And as a research and education subcommittees, our quality subcommittee is multidisciplinary, includes sonographers, attendings, and fellows. We meet every 1 to 3 months, depending on what's going on, to discuss potential projects and other ways to optimize quality of imaging, reporting, and communication. We have learning opportunities like the quarterly multidisciplinary EchoLab QA session. We present 3 to 4 cases with discrepancies or errors, including the images, which surprisingly enough today I have no images to share. We present ones that have learning points, which are given without hierarchy and in a transparent way for team learning. And at the end, we also present some great catches. These sessions are attended by everybody in the Echo Lab, the CT surgeons, and others who are interested. A lot of the times we do have cases that involve surgery, so we started to invite them as well. And we even invite the cath attendings, but oftentimes they're not able to come. We also give updates on QI projects when applicable. We put out action items without patient information after the sessions. And we hope to stimulate ideas for projects, et cetera, by doing this. And people also get MOC credit when they attend. Another way of learning is this echo discrepancy management REDCap. This REDCap, along with the QI tab in the single worksheets, enables all patients undergoing surgery to be entered, and those with an error are emailed to us for review automatically. Our advanced imaging fellow presented this work in 2020 at ACE, and as soon as the REDCap is updated according to the changes in echo billing, we'll continue, and hopefully one of the other senior fellows will publish this work. Some of our QI work is really related to decreasing unnecessary variation in the way we report an image. So we have protocols for many different lesions and also for pulmonary hypertension and heart failure, et cetera. And these are imaging protocols and reporting protocols. And these sort of standardize the way sonographers do the echoes and how the readers read the echoes. We also have a sonographer audit program, which just started in January 2025, where sonographers teach and review audits with other sonographers. So it's really a peer review. They review the imaging and the views that are needed or the ones that aren't needed, because sometimes we do too many views, and when you have 100 clip studies and you're reading 20 to 30 studies a day individually, that may be too many for a lot of the protocols. We have an example of an audit of 30 sonographers that was just done, 45 studies, 38 of them were first CHOP protocols, 5 were Norwood protocols, and 2 were follow-ups. And I'll just say, without showing the clips, that out of the 5 Norwood protocols, the coarctation index, which is an index of the smallest diameter of the reconstructed arch and the largest diameter of the aorta. And if you are below 0.6 for that index, along with tricuspid valve regurgitation and decreased function, you are at higher risk of having a recoarctation. And that enabled us to uh, take these kids to the cath lab before they really got sick. And that was a paper that was published by our group at SHOP. So I think it's really important for some prospective work for us to do that within the protocol at all times. And only one of those sonographers did a Norwood with the coarctation index. So again, a lot of variability and things that need to have improved quality. We have one project that looks at productivity in the Echo Lab. It is called Echo Lab Productivity in the Outpatient Clinic, and we try to reduce the administrative burden of scheduling echo appointments for patients initially booked without one due to unavailable time slots. And we trialed a direct communication pathway from the access center to the Echo Lab instead of going through the administrative assistant. And you can see here that it eliminated the lag time between the visit appointment and the echo appointment, but it also reduced the administrative burden to find echo appointments when you have a clinic visit. So that's also promising. Multidisciplinary efforts outside of the Echo Lab to improve postoperative outcomes in the cardiac center is also one way that the Echo Lab has become involved in other parts of the cardiac center. This is the PRIDE initiative, which is prompt recognition, investigation, and intervention to avoid delayed exit from the cardiac intensive care unit. You could see the SMART aim here and the cohort. These important initiatives do involve echo as part of providing or improving outcomes for these patients. So far, we have developed intraoperative imaging and communication checklists to standardize the imaging of relevant structures in the operating room and communicating any concerning findings to the surgical team to see if they need to do anything else in the operating room itself. We have echo timing and flags so that the first echo is done now within the first 24 hours of chest closure or sooner if the patient is sick. There's a macro in the Norwood, in the echo Singo template that allows for one page where all of the critical findings of the Norwood are there to optimize reading. And now we're in the process of educating sonographers and fellows about this process. We also have clinical targets based on the multi-center PHN research, time to chest closure, time to extubation, and time to removal of all central lines, except for the PICC line. And if a patient doesn't meet the 75th percentile for any clinical target or has an important residual lesion, the patient meets criteria for discussion. In the 2 p.m. review with the surgeon of record, the primary ICU attending, the primary cardiologist, the cath attending if applicable, and the echo and cross-sectional imagers. We have a template now for discussion. And just to say that data collection and analysis is a huge part of this work. And echo also plays a large role to identify important imaging findings as one reason why patients are not doing well. And then there are multi-center efforts like the one Megan just talked about, where it's trying to improve diagnostic accuracy prior to congenital heart surgery. This is an echo-based multi-center collaboration. It's a novel way to approach and decrease errors as a first step to improve surgical outcomes. So using a quality improvement framework with the subset of heart defects that we initially had. We determined patient demographics for a cohort of these defects, baseline error rate, common anatomic areas and preventability of the errors, and patient and center level associations that are associated with these errors. And this just got published in JACC Advances this year. And the next steps are to gather and implement change ideas at the local level, ideas that can be easily implemented no matter what the Echo Lab is. Collecting patient data after these interventions are in place, and then hopefully demonstrate sustained improved diagnostic accuracy. And these are the types of change ideas that we're looking at really in every aspect of the diagnostic evaluation. And most importantly, to implement other innovative change ideas by working together across centers, something that, you know, one lab might be thinking of or already been successful with, to have that go to another lab. So this type of collaboration encourages both small and large centers to participate together. It enables cases with important errors to be reviewed together in a non-judgmental, transparent way for team learning. And I forgot to say that we meet every month to look at the red cap, to discuss these cases and to move the initiative forward. It allows for implementation of diverse change ideas that some centers have already used for successful, sustained improvement. And it really mimics established QI networks like NIPQuIC, like PC4 and PAC3, that really are a QI network that aim to reduce unnecessary variation in care and also incorporate medical providers, families, and patients in multidisciplinary efforts to improve outcomes across across cardiac patients. Thank you.
All right. Thank you, Dr. Natarajan. We are going to do a Q&A session now. I don't see any questions yet in the chat. So if anybody does have questions, if they want to go ahead and type those in now.
I actually have a quick question. Thank you both so much for your presentations. For the QI sections that you have in Singo, do you complete those for every single echo that's performed?
No, so the couple that I showed on kind of comprehensiveness and image quality, those we do just for a subset of patients on a quarterly audit basis. So selecting complete initial studies, usually 2 per sonographer, and going through them once a quarter, and they get sort of distributed among the sonographers and attendings to go through and fill out, but not for every study.
Megan, do you have a way to collect and analyze this data easily?
So through data mining, we should be able to, you know, it's a little bit cumbersome, but I think we would be able to get outputs of, you know, what were the comprehensiveness scores or that kind of thing. And that's something I was actually just talking with Terry Tacey, who built a lot of it.
Yeah. She was my attending when I was a fellow.
Oh, wow.
Yeah.
That's
She
awesome.
was one of my mentors.
But yeah, we thought it would be really interesting to, you know, now that we have many years of audits, to kind of look through and see if, you know, kind of varying experience or varying complexity of different studies, how much that impacts comprehensiveness or image quality.
Great.
We have a question to Dr. Natarajan. Can you elaborate on how did you solve getting echoes for those who weren't ordered ahead?
Okay, so that's are you talking about the productivity? The productivity slide? Yes. Okay. You know, it's a good question, and I don't have a clear answer because I wasn't really a part of that QI project. But I think that it was really just a direct line that instead of the access center contacting the administrative assistant, they just contacted the Echo Lab, the sort of the coordinator in the Echo Lab, to see if there was an echo that fit the visit time. So, because we have Epic Chat, which can be annoying at times, but it can be very helpful at times. So I just think they did it through that. Does that sound appropriate? Yes.
Thank you so much. Sorry. Maybe I should just like unmute myself. I didn't realize I can. Thanks. I think we have the same, it's not efficient to like, we were asked to now pre-order every single echo on the patient that may or may not need an echo
Yes.
and then
Yes.
so what if the patient does not need an echo, so that echo slot is not used, right? And it's not,
Yeah.
and then some other patients who need an echo may not be able to get to use that echo slot. So I think there's both ways from a productivity standpoint, efficiency standpoint. I think I was thinking of like maybe there's a more efficient way in doing this. And I agree with secure chat. It's
Yes.
there should be etiquette on secure chat, and I think
Yes.
they just like launched it without any rules.
Yeah. Yeah. I mean, this is definitely, I agree with you. It's definitely not the end all be all. I mean, that graph did show some, at least some improvement in how they do the work, but it hasn't really solved the work of making it more productive and more efficient so that we aren't canceling echoes at the last minute. I mean, that's the thing about QI. You sort of have to do it in small steps. If you bite too much, it's just going to be really hard to make any headway. So even in our multidisciplinary QI projects, like with the ICU, this project honestly has been going on for quite a few years. And I think it's just taken a while, and we've changed our scope a little bit. And we also have people that want to do the work. So it's just a good time to present it because we're actually moving forward. But it took a long while to do that. So baby steps, I think, for QI.
Thanks so much.
All right, we have one more question in the chat. So Accreditation Canada has recently been working on formal guidelines for pediatric echo labs, and one challenge we have is finding an outside lab that can audit the quality of private labs. Pediatric cardiologists have a very heavy workload, and there aren't enough to assist with the extra tasks such as these. Do you know if there are outside resources that labs such as ours can use to help with these outside audits, specifically in Ontario?
Yeah, I'm not aware of apologies. I'm not sure in Ontario what resources there might be for kind of outside audits. I can speak to how we do ours because we really audit our lab internally. But it's definitely, it takes one of our lead sonographers a lot of time to compile all of the cases to be reviewed and disperse them. Fortunately, because we're just doing kind of a couple per person per quarter, the burden, and the burden is spread over everybody, that it doesn't feel too onerous. And so that's how it kind of gets done. But I think, yeah, in smaller labs, or where there's where time is even tighter, or there aren't kind of sonographer leaders who can have dedicated time to do this work, is definitely challenging. And I mean, for many of the QI projects, like secondary reviews, that's a hurdle, is how that it's non-billable work and everybody has their time very filled. So being able to do those secondary reviews and fit it into the day is challenging as well.
Right. And there's another question. Is the REDCap system integrated with Singo in such a way that the data from the QI Singo section passes into REDCap automatically?
I mean, for our project on echo discrepancies in the OR, it's a direct link. So we get an automatic email from a team that it goes into REDCap and then it comes into an email and it comes to us automatically. There is a link there. And even so far as the accession number and the date of the echo and all of those things come right into the REDCap, into the right space. It was done by an analyst that's no longer here, and he was amazing. So it's the right analyst, really, that makes it happen.
And that might be institution specific as well.
Yeah.
So
Yeah.
our Singo, you're able to link out to REDCap, but it doesn't directly pull from Singo into REDCap.
Got it. Yeah.
Yeah.
Were there any other questions? I didn't see any other ones. Okay. All right. I think really quickly, we would like to do our institutional sponsor. Our sponsor today was Cincinnati Children's, and we do have a representative from Cincinnati on. There we go. Hello.
Hello.
Go ahead and share your screen. Perfect.
Yes, can you see my screen?
Yes, great. Thank you.
Perfect. Okay, thank you. My name is Carlos Villalobos. I'm a faculty at Cincinnati Children's, and I'm part of the Echo Lab. And my main focus of research and main interest is on 3D echo. So I'll use these 2 minutes to talk about our research in 3D and the implementation of this technique at Cincinnati Children's. So first, I'm going to talk about our research, and then I'm going to talk about implementation, just a couple of clips. So the first project I would like to share with you is the assessment of common AV valves in patients with AVSDs. As you know, the complex geometry of these valves makes 3D echo the best tool to assess. And you can see here this common AV valve looking from below and from the atrium. Moreover, using 3D echo, we are able to segment these AV valves in a very detailed way, so we can make analysis, as you can see here. So once we have the 3D model, we can measure diameters, angles, areas, volumes, etc. So as you know, sometimes common AV valves are not very straightforward, so we need to make an extra effort on giving detailed analysis to the surgeon and kind of plan the surgery in complex valves. The second project we're working on is the assessment of pulmonary sinuses. So the idea of measuring and doing the analysis of the sinuses is to create valves to repair aortic valve insufficiencies, for example. So the idea is that the pulmonary sinuses have the same diameter and form as the aortic valve leaflets. So this is a promising technique, just to avoid Ross and other procedures, to reconstruct our aortic valve leaflets using pulmonary sinuses. As this technique, is gaining attention and strength, it is important to assess also the utility of this technique and the outcomes of the implementation of 3D echo. And briefly, I'm going to show you some of the implementation that we're doing. I'll say that the most common structure that we assess are valves. So you can see here an example of a mitral valve. that has flail. This is a patient with Alcapa who had rupture of the chordae. And then on the right, you can see an Epstein's anomaly. That's a tricuspid valve with Epstein's. We also assess semilunar valves. So as you can see here, there's a quadricuspid truncal valve here. And then you see a bicuspid valve here. And on the top, you will see this plastic aortic valve. So this is important information for the surgeons just to plan the repair. We also think there's a potential use for this technique on patients pre-Fontan. So the surgeons really like this assessment, for example, in patients that have more than mild regurgitation through the AV valves. So they would like to see how the AV valve looks like for the repair in preparation for the Fontan. Of course, one of the favorites is the chordae abnormalities. So here you can see a straddling mitral valve. So as you can see, echo is the best tool for chordae assessment, especially when they are abnormal. And the basics, ASDs, VSDs, and other type of shunts, especially when they are complex or they are multiple, or if the surgeon has any question. So that's it. Thank you for the opportunity.
All right, thank you so much. I appreciate that. I'm gonna stop your sharing, and then let me share my screen one more time just to let you guys know our next session. So again, our next session, we're taking the month of June off. So we have ACES PCHD conference at the end of June. And so we will meet up again on July 22nd. We're going to be doing Fellow Bootcamp Part 1. So we're going to be doing an intro to echo and some knobology and ergonomics. I want to give a big thank you to our presenters and our moderators for tonight. We really appreciate all the information. Remember to pay your membership dues, and with that, you will be able to see these recorded presentations on the SOPE website as well. So I hope you guys have a good June, and we will see you back here in July.
Thank you, everyone. And please let your fellows know we will have a call out soon for new fellow members to join our committee. We have a great group of attending sonographers and fellows, and we would like to continue that work together.
Yes, we will be doing that. We'll be giving that end of July, beginning of August, I think. So we will be looking for fellows to help us out. So everybody have a good night. I will see you again in July. Thank you so much.